This is going to be our review from class. The phlebistatic axis approximates the level of the right atrium and is considered to represent the level of the catheter tip. A Trendelenburg position or head-down position may be used during insertion of the catheter to make visualization of the jugular approach easier. But the recommended position for hemodynamic reading is supine. The patient should be placed in a supine position whenever completing a hemodynamic assessment. The zero referencing point must be repositioned with changes in the backrest elevation to keep it at the phlebistatic level. To do this, open the reference stopcock to room air. This is off to the patient, and observe the monitor for a reading of 0. This allows the monitor to use the atmospheric pressure as a reference for 0. Zeroing is done during the initial setup monitoring lines such as the arterial, CVP, Swan GANs. When the transducer has been disconnected from the pressure cable or the pressure cable has been disconnected from the monitor. It is also done when accuracy of the values are questioned. The transducer position directly affects the accuracy, so repeat leveling and zeroing process every time the patient, the pole, or the bed is moved. Cardiac output is the volume of blood pumped by the heart in 1 minute. Think of it as the amount of blood leaving the left ventricle every minute, which is important for adequate tissue perfusion. Cardiac output is heart rate times stroke volume. Now, the cardiac index is the cardiac output adjusted for body size. It is a more precise measurement of the efficacy of the pumping action of the heart than cardiac output. Central venous pressure is the right ventricular preload or right ventricular end diastolic pressure under normal conditions. It's measured in the right atrium or in the vena cava close to the heart. CVP catheters can measure oxygen saturation of hemoglobin in venous blood. The mean arterial pressure is calculated using a basic formula: systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. The goal is that you want to keep the mean arterial pressure greater than 70 millimeters of mercury. Now, the first one you look at, that is a normal cardiac output, like 4 to 8 liters a minute. If you see the low cardiac output, this is one, think of it like a babbling brook. It's going to take a long time for it to go from beginning to end. Whereas if you look at the high cardiac output like a raging river, then it's very quick from where it starts and where it could return, kind of like in a circular jacuzzi. The high cardiac output would represent that they would have a lot of volume, whereas the low cardiac output shows that they don't have as much volume. That's why it takes longer for it to go from beginning to end. I like this picture because it looks at what affects cardiac output. Obviously, the heart rate, altered contractility. Either the preload or afterload is reduced or there's too much. Stroke volume and dysrhythmias. Stroke volume is the amount of blood leaving the left ventricle with each heartbeat. High stroke volume is seen with bradycardia and exercise and with use of positive inotropes like dopamine. Changes in stroke volume are becoming more important indicators of pumping status of the heart than many of the other parameters. Stroke volume index is stroke volume adjusted for body size. Systemic vascular resistance index, stroke volume, and stroke volume index can all be calculated when cardiac output is measured. Normal systemic vascular resistance is 800 to 1200 dynes a second. Systemic vascular resistance, or afterload, is the pressure the heart pumps against to get the volume out to the lungs or to the body. If that pressure is increased, but volume measured by cardiac output stays the same, it means that the heart is working harder to get the volume out and the blood pressure will go up. Increasing systemic vascular resistance with no change in cardiac output does indicate a change in blood pressure. The blood pressure would increase initially in response to the increased workload. If treatment is not initiated, the heart will eventually tire and a decrease in blood pressure would be expected. With diuretic use, the systemic vascular resistance should also normalize. So a high SVR, systemic vascular resistance, can happen from vasoconstriction from shock, hypertension, increased release of administration of epinephrine or other vasoactive inotropes, left ventricular failure, a decrease in systemic vascular resistance or SVR, vasodilation, or shock states and drugs that decrease the afterload. Preload is the volume of blood within the ventricles at the end of diastole. As preload increases, the force generated in the subsequent contractions increase, so that the stroke volume and the cardiac output increase. Right ventricular preload depends on the volume returning to the right atrium. Preload is measured by the CVP, the right atrial pressure, the pulmonary artery wedge pressure, or you also may hear pulmonary artery occlusion pressure. Preload is decreased during vasodilation or hypovolemia. So giving us, say, a 500 ml normal saline fluid bolus would be expected if their preload was low. Preload is increased during hypervolemia and ventricular failure. Afterload is the force that opposes ventricular ejection. It is the resistance offered by the aortic valve. It's the resistance the ventricles must overcome to eject the blood. The right ventricle is affected by pulmonary vascular resistance. The left ventricle is affected by systemic vascular resistance. Reduced afterload lessens cardiac workload. Excessive afterload strains the ventricles and increases oxygen demand. The pulmonary artery catheterization is the insertion of a catheter into the pulmonary artery. Its purpose is diagnostic and used to detect heart failure, sepsis, monitor therapy, and evaluate the effectiveness of drugs. The pulmonary artery catheter allows direct, simultaneous measurement of pressures in the right atrium, the right ventricle, pulmonary artery, and the filling pressure, the wedge pressure, of the left atrium. The PA and CVP catheters can measure oxygen saturation of hemoglobin in venous blood. Now, the SVO2 and the SCVO2 reflect balance between oxygenation of arterial blood, tissue perfusion, and tissue oxygen consumption. Tissue oxygen consumption is known as VO2. Normal SVO2 and SCVO2 at rest is 60 to 80%. As a nurse, you're observing for changes in arterial oxygenation by blood gases, monitoring pulse oximetry, and indirectly assessing the cardiac output and tissue perfusion. This is done by noting any changes in mental status, the strength and quality of their peripheral pulses, capillary refill, urine output, skin color, temperature. A decrease in SVO2 and SCVO2 could result in decrease in arterial oxygenation, low cardiac output, low hemoglobin level, increased oxygen consumption. In sepsis, the oxygen is not extracted properly at the tissue level, which results in an increased SVO2 and SCVO2. If there is an increase in SVO2 and SCVO2, it may indicate clinical improvement. There's an improved arterial oxygen saturation, or a worsening in the clinical condition if the patient has sepsis. Think about what you as a nurse can do to improve gas exchange. Maintain a patient on bed rest to reduce oxygen demands during acute respiratory distress, increasing the activity gradually as allowed and tolerated. Maintain oxygen therapy as ordered. Discourage smoking, because you know that carbon monoxide in smoke decreases oxygen availability and the nicotine can cause vasoconstriction and then further reduce pulmonary blood flow. Think about what actions can be done to improve pulmonary blood flow. Well, administering anticoagulants, continuous intravenous heparin, low molecular weight heparin, or warfarin as ordered, right? Because now we're saying pulmonary blood flow. Maybe the patient needs to be prepared for injection of a thrombolytic agent like streptokinase or alteplase, the TPA, or maybe need to go for an embolectomy. We think about other things that can be done when we're trying to improve cardiac output or gas exchange or anxiety. Now, Valium may help decrease the anxiety, but it's not intended to improve cardiac output or gas exchange. You might increase dopamine, and that could provide cardiac output, but it's also going to increase the heart rate and myocardial oxygen consumption. Well, then there's nitroglycerin. That can improve cardiac output and might be appropriate, but it's not going to reduce anxiety. So then we come back to the drug morphine. And morphine improves alveolar gas exchange. It improves cardiac output by reducing ventricular preload and afterload. It decreases anxiety and assists in reducing the subjective feeling of dyspnea. Here's a cute picture I found. I swear I'm an artery, pulmonary division. Now, contractility is said to increase when preload is unchanged, yet the heart contracts more forcefully. Force of the cardiac muscle that is increased by sympathetic nervous system stimulation with positive inotropic medications. Increased contractility results in increased stroke volume and increased myocardial oxygen requirements. Contractility is reduced with negative inotropes. Examples would be alcohol, calcium channel blockers, beta-adrenergic blockers, and clinical conditions like hypoxemia and acidosis. Meds that improve or increase contractility: epinephrine, norepinephrine, also known as Levophed, isoproterenol, also known as Isoprel, dopamine, dobutamine, digitalis-like drugs, calcium, and milrinone. Again, all of these agents are termed positive inotropes. Now, the proximal intake port of the primary port is used for obtaining cardiac output via boluses of iced or room temperature normal saline. Because of the risk of an inadvertent bolus of potent medications, neither vasopressors nor vasodilators should be administered through the same port used for obtaining a cardiac output. It would be safer to infuse vasoactive drugs through the proximal infusion port. The distal port is the design port for continuous monitoring of the pulmonary artery pressure and for obtaining the pulmonary artery wedge pressure. The traditional method of thermal dilution cardiac output uses a 10 ml bolus of injectate. In order to overcome arterial pressure and prevent blood from backing up into the pressure tubing, a pressure bag placed around the flush solution should be inflated to about 200 to 300 millimeters of mercury. When inflating for a pulmonary wedge pressure, the smallest inflation volume possible should be used, typically less than 1.5 mLs, which will reduce the risk of balloon rupture. Resistance may indicate that the balloon is compromised in the artery, and the nurse should stop inflation, allow the balloon to passively deflate, and then call the healthcare provider. Passive deflation should be used to avoid damage to the balloon. The balloon should be completely deflated to avoid a continuous wedge, which could lead to a pulmonary infarction. Pulmonary artery wedge pressure is measurement of the pulmonary capillary pressure and reflects left ventricular and diastolic pressure under normal conditions. Normal pulmonary artery wedge pressure is 4 to 12, so 16 is too high, and that would indicate a high preload, and a nurse could probably anticipate giving a diuretic and a vasodilator to help reduce preload. A wedge pressure of 2, now that's significant hypovolemia. And if you're looking at this picture and you see where a patient has a pulmonary artery waveform and then wedge waveform begins to show, this is indicating catheter migration further into the pulmonary artery and causing an occlusion. And if it migrates backwards, then you might see the waveform for the right ventricle. Both are considered emergencies. The pulmonary diastolic pressure and the pulmonary artery wedge pressures are indicators of cardiac function and fluid volume status. Monitoring the pulmonary artery pressures allows therapeutic manipulation of preload when measurements are obtained. Pulmonary artery is done at end expiration. Pulmonary artery wedge pressure by inflating the balloon with only enough air until the PA waveform changes to a wedge waveform. The balloon should be inflated slowly and for no more than 4 respiratory cycles or 8 to 15 seconds. The pulmonary artery diastolic and pulmonary artery wedge pressure decrease with volume depletion. Fluid therapy based on PA pressure can restore fluid balance while avoiding overcorrection or undercorrection of the problem. Continuous arterial pressure monitoring is needed for acute hypertension or hypotension, respiratory failure, if the patient's in shock, neurologic shock, coronary interventional procedures, continuous infusion of vasoactive drugs, and frequent arterial blood gas sampling. Continuous flush irrigation system delivers 3 to 6 mLs of heparinized saline per hour, maintains line patency, limits thrombus formation. So think, how would you know there's neurovascular changes? The limb with compromised arterial flow will be cool and pale with a capillary refill greater than 3 seconds. Symptoms of neurologic impairment like paresthesia, pain, paralysis, you might also see. Neurovascular impairment can result in loss of limb, and this is an emergency. If you look at this picture on the right, the cannula shown entering the radial artery is connected via a pressure, non-distensible tubing to a transducer. The transducer converts the pressure wave into an electrical signal. The transducer is wired to an electrical monitoring system which amplifies the condition and displays and records the signal. Stopcocks are inserted into the line for specimen withdrawal and for referencing and zero balancing procedures. A flush system is consistent of a pressurized bag of IV fluid, tubing, and a flush device is inserted into the line. The flush system provides continuous flow, approximately 3 mLs an hour, of flushing and provides a mechanism for fast flushing of the lines. Looking at this picture at the top, you can see why it's very important to do monitoring, hourly monitoring on a patient with an arterial line. Nursing interventions, monitoring the blood pressure, administer and titrate vasoactive medications, assess the effectiveness of the medications. Always assess a patient condition when a monitor alarm sounds. Validate abnormal arterial blood pressure against manual cuff blood pressure. Check the patient's status before troubleshooting equipment. Change the dressing per institution protocol. Assess the site for infection. and discontinue the intra-arterial catheter when the blood pressure is stable, and then observe the catheter site after removal. It's important that you correlate a manual blood pressure with an arterial line pressure to ensure its accuracy. The dicrotic notch represents closure of the aortic valve. This dicrotic notch represents the beginning of ventricular diastole. When the aortic valve opens, this forms a steep upstroke on the arterial waveform called the anacrotic limb. The top of this limb represents the peak or highest systolic pressure. After the waveform reaches its peak, it begins to descend, and this descent forms the dicrotic limb and represents systolic ejection of blood that is continued at a reduced force. The lowest portion of the waveform represents the diastolic pressure and is reflected digitally on the monitor. Prior to having the insertion of the arterial line, it's important to do the Allen's test. To perform the Allen's test, if the color returns in less than 7 seconds, then it's a positive test. If the color returns in greater than 15 seconds, then that's a negative test, and you would report the negative results. Nursing assessment of the central venous catheter pressure is to assess for baseline, contraindications, complications, monitor the pressure, and patient education. Interventions and rationales is that the nurse is responsible for all lines, monitoring the CVP, level and zero the transduction per hospital policy, which could be every 4 hours or every shift, and definitely as needed when you move the patient, the pole, or the bed. Evaluate heart rate, blood pressure, and urine output. A potential complication would be infection. A higher risk complication would be air embolus or pneumothorax. Your outcome is no infection, no bleeding, stabilization of the pressures, and discontinue the CVP line. Pulmonary artery catheter. The nursing management is responsibility for all lines. Monitor pressures of the pulmonary artery and the cardiac output. Alert the care team of anticoagulation status prior to insertion, and also of any altered electrolytes and acid-base balance prior to insertion of the pulmonary artery catheter. Interventions and rationale. Prepare and test all equipment. Monitor and evaluate the waveform, changes during the insertion, inflate the balloon when the catheter tip is in the pulmonary artery, monitor ventricular ectopy throughout the procedure, document procedure including distance of insertion, apply an occlusive dressing, care for the dressing changes and assessing for infection, troubleshoot equipment if needed, reassess the patient when readings change. The outcome is that the pulmonary artery readings stabilize to within normal limits, normal or stable cardiac output, no infection, no bleeding, and the goal is for the pulmonary artery catheter to be discontinued when patient stable. Complications with the PA catheter include infection, pneumothorax, or air embolism, especially if it gets inadvertently disconnected. Others would be pulmonary infarction, pulmonary artery rupture. Another complication is balloon rupture, where it's called a particle embolus. The catheter could coil. The catheter could displace and cause a permanent wedge. Patient could have dysrhythmias and conduction defects. During a PA catheter insertion or removal, if the tip migrates back into the PA to the right ventricle, or the PA catheter cannot be wedged, it may need repositioning, but this would be done by a physician. Pulmonary infarction or PA rupture, if the balloon ruptures due to overinflation, or prolonged inflation, spontaneous wedging, or a thrombus embolus formation. Each of these can cause pulmonary infarction or a PA rupture. So to prevent a PA rupture and a pulmonary infarction, check the PA pressure waveforms often for signs of catheter occlusion, dislocation, or spontaneous wedging. Continually flush system with a slow infusion of heparinized saline solution. To reduce these risks, never inflate the balloon beyond the balloon's capacity, less than 1.5 mL of air. Nursing management. Obtain baseline data and correlate the baseline data with the data obtained from the ECG, the arterial CVP, PA, and wedge pressures. Also look at the SVO2 and the SCVO2. Single hemodynamic values are rarely significant. You must look at all of the numbers together and monitoring the trends and evaluate the whole clinical picture. Look at the patient. Does the patient appear tired, weak, or exhausted? Cardiac reserve may be insufficient to sustain even minimal activity. The level of consciousness. Changes in mental clarity may reflect problems with cerebral perfusion or oxygenation. Their vital signs, peripheral pulses. The skin color, pallor, cool, diminished pulses could also indicate a decrease in cardiac output. Urine output. Monitoring urine output reflects the adequacy of perfusion to the kidneys. and the goals are to recognize early clues and intervene when problems develop or escalate. Acute myocardial infarction, complications, dysrhythmias, heart failure, pulmonary edema, cardiogenic shock, thrombophlebitis, and pericarditis. Interventions in the acute stage place the patient in a semi-Fowler's position, administering oxygen, nitroglycerin, antidysrhythmics as prescribed, assess cardiac status and respiratory status. Interventions following an acute episode is bed rest, range of motion exercise as prescribed, activity progression as tolerated and as prescribed, and monitor for complications. Cardiac rehab is to arrange for the patient to begin before discharge. Now remember, a bruit is a sound created by turbulent blood flow in an artery. Thrills are palpable vibrations felt when there is turbulent blood flow through the heart or in a blood vessel. A murmur is a sound caused by turbulent blood flow through the heart. Auscultating a bruit in an artery is not normal and indicates pathology. Valvular heart disease. This happens when heart valves are stenosed, cannot fully open, or insufficient or regurgitant, cannot close completely. Murmurs are caused by turbulent blood flow, such as occurs when the blood flows through a damaged valve. Relevant information includes the position in which the murmur is heard best, sitting and leaning forward, the timing of the murmur in relation to the cardiac cycle, systole and diastole, and where on the thorax the murmur is heard best. Repair procedures: balloon valvuloplasty, mitral angioplasty, commissurotomy, or valvotomy. Valve replacement procedures: mechanical prosthetic valves or bioprosthetic valves. And general interventions: administer prescribed treatment for heart failure, such as oxygen, IV fluids, diuretics, digoxin, low-sodium diet, or antibiotics, and each of these as prescribed. For mitral stenosis, assess for dyspnea, orthopnea, a rumbling apical diastolic murmur, and pitting peripheral edema. A mitral valve prolapse, assess for fatigue, atypical chest pain, palpitations, syncope, or systolic click. Mitral insufficiency or regurgitation, assess for dyspnea, orthopnea, dizziness, signs of right ventricular failure, pitting peripheral edema, high-pitched systolic murmur, and a systolic murmur and a palpable throw would be expected in a patient with mitral regurgitation. Aortic stenosis, assess for dyspnea on exertion, angina, syncope, orthopnea, harsh systolic crescendo-decrescendo murmur. Chest pain occurring with aortic stenosis is usually caused by cardiac ischemia. A systolic murmur and thrill are expected in a patient with aortic stenosis. Aortic regurgitation. Assess for dyspnea, orthopnea, angina, tachycardia, blowing decrescendo diastolic murmur. Hypotension in patients with acute aortic regurgitation may indicate cardiogenic shock. Nurse should immediately assess the patient for other findings like dyspnea or chest pain. Tricuspid stenosis. Assess for effort intolerance, cyanosis, decreased cardiac output, peripheral edema, and rumbling diastolic murmur. Tricuspid insufficiency or regurgitation. Assess for signs of right ventricular failure, ascites, pleural effusion, peripheral edema, and systolic murmur at the left sternal border. Tricuspid valve prolapse. An abnormal protrusion of one or more leaflets of the tricuspid valve into the right atrium during systole. This allows the backflow of blood into the right atrium, leading to tricuspid valve insufficiency, causing systolic murmurs. The most common cause is not primary valve abnormality, but rather the dilation of the right ventricle and the tricuspid annulus. Pulmonary stenosis. Assess for dyspnea, syncope, signs of right ventricular failure, ascites, and systolic thrill heard at the left sternal border. Pulmonary insufficiency or regurgitation. Assess for signs of right ventricular failure, ascites, systolic thrill at the left sternal border. Complications of valvular disorders, a venous thrombus, and this is associated with the inflammatory process. Anytime a patient has any kind of suture lines on the lower extremities, they should not be sitting for long periods of time to decrease the stress on the suture line. If they are sitting up in a chair for long periods of time, this increases the stress on the suture line caused by leg edema, and this would be a risk for venous thromboembolism. Phlebitis is vein inflation associated with invasive procedures such as IV lines. Deep vein thrombophlebitis. This is much more serious than superficial thrombophlebitis because of the risk for pulmonary embolism. Elevate the affected extremity above the level of the heart and avoid using a knee gatch or pillow under the knees. Do not massage the extremity. Venous insufficiency results from prolonged venous hypertension. Varicose veins are distended, protruding veins that are evident and appear darkened and tortuous. Damage after myocardial infarction is inability of the heart to maintain adequate circulation to meet the metabolic needs of the body. The types of heart failure: right ventricular, left ventricular, forward failure, and backward failure. Compensatory mechanisms is to try to restore cardiac output to near normal levels. This is included by increasing the heart rate, improving the stroke volume, arterial vasoconstriction, sodium and water retention, and myocardial hypertrophy. Mild fever and hyperglycemia are common after an MI because of the inflammatory process that occurs with tissue necrosis. Left-sided failure presents as primarily respiratory symptoms including orthopnea, cough, adventitious breath sounds, tachycardia, and dyspnea on exertions. Crackles that are audible throughout the lungs indicate the patient could be experiencing severe left ventricular failure with pulmonary congestion and would need immediate intervention such as a diuretic. Right-sided failure presents as primary systemic symptoms including jugular vein distension, dependent edema, ascites, and hepatosplenomegaly. When the patient is lying flat, the jugular veins are at the level of the right atrium, so a jugular vein distension would be common but not necessarily a clinical significant finding. Jugular venous distension is an expected finding when a patient performs a Valsalva maneuver because the right atrial pressure increases. Jugular venous distension that persists when the patient is sitting at a 30 to 45 degree angle or greater is significant. For a patient in heart failure, immediate management is to place the patient in high Fowler's position, administer oxygen, suction patient, monitor vital signs, strict I&O, administer diuretics, morphine, and DIG as prescribed. Following acute episodes, instruct the patient about modifiable risk factors. Instruct the patient on proper administration of medication regimen and to avoid over-the-counter medications. Instruct the patient to eat a low-sodium, low-fat, low-cholesterol diet and how to balance their activity levels. A home health nurse may be needed to assess the patient's home situation and help the patient develop a method for taking more than 2 medications as directed. Pulmonary edema presents as pallor, dyspnea, orthopnea, and large amounts of blood-tinged mucus and diaphoresis. Pulmonary congestion and tachypnea suggest that the patient may be developing heart failure, a complication of a myocardial infarction. Cardiogenic shock is failure of the heart to pump adequately, which reduces the cardiac output and compromises tissue perfusion. Nursing assessment is to monitor the blood pressure less than 90 millimeters of mercury systolic or 30 millimeters of mercury less than a patient's baseline. You're assessing for oliguria, poor peripheral pulses, tachypnea, tachycardia, disorientation, confusion. Intervention would be administer oxygen and possibly prepare for intubation and mechanical ventilation as prescribed, administering morphine sulfate IV, diuretics, nitrate as ordered. Prepare the patient for surgery if warranted. Monitor vital signs, arterial blood gases, strict I&O, arterial pressures as ordered. Hemodynamic monitoring could be central venous pressure, pulmonary artery pressures, and monitoring the mean arterial pressures. Cardiac tamponade, you'll see a pericardial effusion that occurs when the space between the parietal and visceral layers of the pericardium fill with fluid. Assessment is pulsus paradoxus, increased central venous pressure, jugular vein distension with clear lungs, distant muffled heart sounds, decreased cardiac output. During the assessment, the patient may also experience paroxysmal nocturnal dyspnea, or pulsus alterans, which is an alteration of strong and weak peripheral pulses during palpitation. The patient may need to be in a critical care unit, administer IV fluids, and prepare the patient for a possible pericardiocentesis. Also monitor for reoccurrence of a tamponade following the pericardiocentesis. Pericardial friction rubs are heard best with the diaphragm at the left lower sternal border. The nurse should ask the patient to hold his or her breath during auscultation to distinguish the sounds from a pleural friction rub. Friction rubs are not typically low-pitched or rumbling and are not confined to systole. Rubs are not assessed by palpitation. Pain associated with pericarditis is caused by inflammation, so non-steroidal anti-inflammatory drugs like ibuprofen are most effective. Opioid analgesics are usually not used for pain associated with pericarditis. Pleuritic pain is that stabbing chest pain that increases with deep breathing. That first action by the nurse should be to listen for a pericardial friction rub. Paroxysmal nocturnal dyspnea is caused by the reabsorption of fluid from dependent body areas when the patient is sleeping and is characterized by waking up suddenly with the feelings of suffocation. Aortic aneurysms. This is an abnormal dilation of an arterial wall caused by localized weakness stretching in the medial layer or wall of the artery. The types of aortic aneurysms are fusiform, saccular, and dissecting. Assessment is that the pain would extend to the neck, shoulders, lower back, abdomen, and visible pulsations in the abdominal aortic area. Patient could be experiencing syncope, dyspnea, tachycardia, and cyanosis. Now, if the patient has a visible pulsation in the abdominal aortic area, observed in the epigastric area could be considered normal for thin and elderly individuals. The assessment should focus on sudden, sharp, and worst ever upper back pain. A patient's presentation would be consistent with a dissecting thoracic aneurysm, which would require rapid intervention. Pharmacological interventions: administer antihypertensive as prescribed to maintain the blood pressure within normal limits. The goal is to prevent strain on the aneurysm. Abdominal aneurysm resection would be a surgical resection or excision of the aneurysm. Postoperative interventions would be to monitor the vital signs and peripheral pulses distal to the graft site. Limit elevation of the head of the bed to 45 degrees. Strict intake and output. Assess incisional site for bleeding, signs of infection, and instruct the patient not to lift objects heavier than 15 to 20 pounds for like 6 to 12 weeks. Instruct the patient to avoid strenuous activities. A thoracic aneurysm repair is that the aneurysm is excised through the thoracic cavity. Interventions postoperatively would be similar to an abdominal resection.